Good morning, everyone. I am Dr. Chakradhar Singh from Max Hospital, Lucknow, and I will be presenting my oral presentation on performance of intestinal lymphomas. The first case is a 47-year-old male who presented with a complaint of acute pain in the abdomen and vomiting and distension since 1 day. The patient was already known case of hypertension and diabetes. On per abdominal examination, the guarding rigidity and decreased bowel sounds and tenderness was present. So a clinical diagnosis of perforation peritonitis was made. And the X-ray revealed gas under the diaphragm pointing towards intestinal perforation. These were the lab investigations. And the USG abdomen also revealed mild fluid in the peritoneal cavity. So the patient underwent exploratory laparotomy with resection and anastomosis. This was intraoperative course was such like that, and approximately 70 centimeters jejunum was resected and anastomosis was done in 2 layers. Post-operatively, the patient went into renal failure and shock and died due to sepsis on the 2nd day. Now we received the specimen of 2 loops of bowel showing perforation at multiple sites. On cut surface, there was a thickening of the surrounding adipose tissue, and a great and growth was seen. Macroscopic examination revealed diffuse infiltration of a medium to large size cells, lymphoid cells, and some necrosis was seen. Immunohistochemistry pointed towards CD20 positivity, indicating that B cell lineage, and BCL6 and CD10 was also positive. So our diagnosis of diffuse large B cell lymphoma, germinocenter type 8. Now my second case is of a 30-year-old female who also presented with acute pain in abdomen and vomiting since 2 days. She was already on the antitubercular therapy. So a clinical diagnosis of abdominal tuberculosis was made in some other hospital. When she presented to us, a CT scan was done, and there was multiple foci of air in the interbowel region and anterior to liver. So the patient also had exploratory laparotomy and anastomosis for perforation. Now we received the specimen, and this specimen also the bowel was thickened and there was perforation in the jejunum. On macroscopic appearance, there was villous atrophy with increased intraepithelial lymphocytes and infiltration of tumor cells extending up to the serosa. IHC was positive for CD56 and for BCL2 and CD3 and CD2. So our clinical diagnosis of monomorphic epitheliotropic T cell lymphoma was made. This patient also died on the 2nd day due to cardiopulmonary arrest. Now, intestinal perforations, there are many causes of it, and some common ones include iatrogenic or trauma and infective. But malignancy is also a cause, and it can also present as intestinal perforation. And in fact, GI lymphomas are the most common malignant tumors of the intestine, and out of them, 9% present with perforation, and approximately half of them are post-chemotherapy. And on BCL is the most common intestinal lymphoma, diffuse large B-cell lymphoma, and most common site is the stomach, followed by small intestine. And these are some low-grade lymphomas like marred lymphoma, ipsid, and follicular lymphoma. And the rare ones include mantle cell lymphoma and Burkitt lymphoma. But in my case was of diffuse large B-cell lymphoma. It can be of 2 types, germinocenter type and activated B-cell type. The activated B-cell type has worse prognosis than germinocenter type, and now other cases of monomorphic epitheliotropic T cell lymphoma. It was previously known as type 2 enteropathy associated T cell lymphoma. It is considered to arise from intraepithelial T lymphocytes, and it's quite rare. Only 5%. It constitutes only 5% of the GI lymphomas. It is positive for CD8 and 56 and MATK1, and there is no history of celiac disease in monomorphic epitheliotropic T cell lymphomas. But in this case, we was not able to get the history of celiac disease because the patient directly presented in the clinical history of the perforation and on. Now, my conclusion is clinicians must be familiar that intestinal lymphomas can also present as perforations, and it should be present in the differential for workup of the patient. Thank you.